Hello everyone, and welcome to the On Knowing Another's Pain, Reactions of Healthcare Professionals and Others webinar. We're glad you're here today. My name is Tanya Hyde, and I'll be moderating the webinar. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD, ourselves, and Pain BC, in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Community Gaming Grant Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session. And our presenter today is Dr. Ken Craig. Ken Craig has had a long-standing career as a clinical psychologist and research investigator working towards a better understanding and control of pain. He is Professor Emeritus in the Department of Psychology at the University of British Columbia and Editor-in-Chief of the Pain Research and Management. His current research is supported by the Canadian Institutes of Health Research and the U.S. National Institutes of Health. His research focuses on pain assessment, nonverbal communication, social parameters of care, delivery, and pain in infants and children, and people with communication limitations. And he is also a longstanding board member of our organization, CIRPD. So we're happy to have you here today, Ken.
Thank you, Tanya. Well, good morning, everyone. It's a pleasure to have the opportunity to speak with you. I will be describing a perspective that's emerged over many decades of research and professional practice. I should point out that I am no longer a registered clinical psychologist, although I remain very heavily invested in research. So to set the stage, what I'd like to accomplish today would be to encourage everybody to have a broader appreciation of our social worlds as they determine whether we are exposed to pain, how we suffer, how we communicate our distress to others, and how they react to us. To narrow down, I'd like to focus on the potential for social biases in both how we present our pain to others verbally and non-verbally, and also how healthcare professionals, family members, friends, bystanders, and the like appraise the painful expression of other people, and rather broadly to help you appreciate that pain assessment is a social transaction in which there's an extensive information exchange between both the person in pain and others, with all kinds of reciprocal influences going back and forth. Pain, of course, is a modern scourge, not well recognized or appreciated or managed in the healthcare system. There are many different forms of pain. Most of us really do understand everyday pain, the bruises, cuts, sprains, fractures, burns, and the like that are inevitable, definitely more common in very young children, but continuing throughout life, and certainly characteristic of elderly people. These forms of pain, these experiences, are typically self-limiting. Our wonderful biological capacities for healing take place. I do think that most people's models of pain, our perspectives on pain, represent this form of everyday pain in which there's many ways equivalence between the painful experience and the nature of the injury. Understanding the biology makes good sense because then one can appreciate the medical interventions that are likely to be successfully applied, pharmaceutical and otherwise. Unfortunately, this model doesn't work particularly well, particularly when we're talking about chronic pain. And so there often isn't a proportional relationship between the magnitude of the tissue damage or injury or disease and the severity of the painful experience or the disability that relates to it. understanding the biology is important but insufficient to broadly appreciate the nature of what's happening to the individual. And we have to get beyond biomedical interventions into the psychological and social spheres of the individual's life to help them. Beyond everyday pain, we need to think about acute clinical pain, which is virtually inevitable for all of us in the course of life: injuries, diseases, surgery, and other medical procedures. Fortunately, these are of a relatively short time cycle and can be managed well through biomedical intervention, but we're increasingly recognizing the risk of chronic pain associated with acute clinical pain. And finally, there's chronic pain, pain that's associated with chronic diseases such as arthritis, pain that's associated with terminal illnesses such as cancer, HIV, AIDS, and the likes, and also the medically unexplained syndromes for which the best biomedical diagnostic procedures are unsuccessful in specifically identifying a biomedical cause. These challenges, the chronic pain is endemic in the Canadian population as it is worldwide. We're talking about 20 to 30% of the Canadian population suffering from chronic pain, and yet few resources are really devoted to taking care of this. I'd also like to put a plug in for pain in vulnerable populations. People with intellectual, cognitive, emotional, and physical disabilities suffer even more pain than the typical Canadian. So I'd like to take an evolutionary perspective. I like this statement by Theodosius Dobzhansky, who was a great physiologist and geneticist. He makes the point that our species, Homo sapiens, is a highly evolved species. He concludes that arguably, therefore, nothing in human affairs makes sense except in the light of evolution. And I'd like to speak to that particular theme. In lecturing, I'll often ask a class, why does pain exist? And if I allow the audience to respond, invariably they point to these clearly recognizable adaptive functions that relate to survival of the individual and the species. Pain warns of tissue damage or stress. It motivates escape or avoidance of those particular situations. And in more evolved, complex organisms, it teaches them about dangerous situations so they can avoid those kinds of situations in the future. Less well recognized are the intrapersonal functions of pain. The fact that evidence of painful distress is recognized by conspecifics, other members of the species, and they can use that information to enhance their own survival. And I'm not just thinking of humans or highly evolved non-human primates, but mammals in general, and indeed in avian and insect populations, this kind of interpersonal communication is extremely important. The oh dear, I've made a mistake. That should read interpersonal functions, not intrapersonal functions. Social functions is what I should have up there. These warning cues also can instigate empathy and care. This isn't automatic, and it's probably less frequent than we would like it to be, or than it usually is assumed to be. The interpersonal functions also signify competence capabilities. While this has not been thoroughly researched, I think it's important because people in chronic pain tend to sink down social hierarchies in our society, and we need to appreciate that better. Love this little slide because it shows how well non-human primates are able to communicate their distress. The baby gorilla who hates the cold stethoscope. Excuse me, I've got a cough. But even more so, I love this slide which my son sent me a year or so ago that I think wonderfully demonstrates the continuity of species. What those two slides miss is the social nature of our being, the fact that pain is typically experienced in the presence of other people. This little girl with the nurse or technicians and her mummy going through routine immunization injections. These are commonplace in our society. The social factors are exceedingly important here, as we now recognize in the development of strategies to minimize immunization pain through the use of pharmaceuticals, comfort, relaxation, distraction, all kinds of psychosocial interventions that can be applied. Work by Anna Taddy at the University of Toronto and her colleagues is demonstrating this very nicely. I love this slide because it shows the social nature of the painful experience, and you begin to get a feeling for different reactions on the part of observers. These children who are amused, this guy here and this guy back here who are taking it all in and perhaps becoming more apprehensive in consequence of observing the lad away over on the left here. This paper I pulled out of the Phoenix newspaper, The New Mexican, in 2003, because it brilliantly demonstrates many of the social dimensions of pain. So Christy here was born too short, and she succeeded in convincing her dad and the physicians, the medical community, that it would be in her personal interest to have her legs lengthened. So as a result of these surgical procedures, she grew from 4'3" to 4'10". But I feel for her, I feel for her dad who's comforting her, and I feel for the physician who is professionally committed but no doubt suffers in consequence. And I guess the vicarious trauma that medical and nursing practitioners suffer in emergency burn units, intensive care units, illustrates the fact that observing others in pain can be a brutal experience for them. So I'm very much focused on the social determinants of pain. I feel strongly that social factors have a causal role, that they determine exposure to painful events, leaves room for all kinds of preventive programs. They determine the qualities of experience, how we think and feel, as well as how we sense the painful experience. Pain expression, I'll talk a lot about that as we move along, is heavily determined by the social environments in which we find ourselves, as well as pain disability. And the social factors also relate to what others actually observe and whether and how they provide care. So I operate very much within the biopsychosocial model of pain, with all of these determining the well-being of the individual. But I do feel that the social contexts of pain have not received as much attention as they deserve. This is my social communication model of pain, addresses not only the physical trauma, the personal experience of pain and pain expression, but I argue strongly that we have to pay attention to the caregiver and how they engage in pain assessment and how this affects pain management if we truly want a comprehensive model of pain. And I think all of these are determined by biological factors and the personal history, both of the person in pain and the caregiver, and by interpersonal factors. The immediate context will influence the nature of the pain experience, how it's expressed, how others decode what's happening to the individual and their immediate contexts. Again, from the evolutionary perspective, I like this slide because it demonstrates the relative size of the brain of a mouse, the macaque monkey, and the human. In many ways, the human brain evolved in response to the complexity of life in social environments. This graphical rendering of the brain derived from Paul MacLean's very interesting work on the triune brain. He was popular in the 50s and 60s and distinguished between the cerebrum, the neocortex, which is so prominent on your brain and my brain, the mammalian midbrain, largely the limbic system, responsible for emotions, feelings, and the like, and what he characterized as the reptilian complex, the old brain, very much responsible for vegetative functions, so breathing, respiration, visceral activity, and the like. I like that distinction because it points out that in humans we have this neocortex, which is so responsible for the social interactions important to us. Now, Paul MacLean's work has not been without criticism in terms of the language that he used and the anatomical locations that he paid attention to, but generally it stands up. So I'm beginning to focus on the social factors that relate to knowing the pain of another. Both self-interest and other interest are implicated in this process. Early in evolutionary development, self-interest would have been of overwhelming importance. Observing the pain of others would warn of personal danger, provide opportunities to avoid same, facilitate learning of dangerous environments. I guess I've already said this. It also is associated with other interest, introduces opportunities to help, it allows us to recognize the potential for intervention, and it evaluates, we learn to evaluate the success of our interventions as well. That's one of the benefits of good pain measurement. I do think that self-interest is of primary importance, that other interest emerges relatively late in evolutionary development with the exclusion of the maternal-infant relationship, which in many ways is paradigmatic of altruistic engagement, but the altruistic impulses in adults, I think, are subject to relegation to secondary importance, where issues of self-interest impose themselves. Knowing somebody else's pain is hugely complex, like this slide put together by Apkarian, Bushnell, Treat, and Zubieta, because it represents the complexity of the regions of the brain that are involved, implicated when people are experiencing pain. So not only is there activity in the sensory cortex, but the midbrain, the limbic brain, this region of the brain associated with affect, and the prefrontal cortex, that region of the brain associated with executive control and the higher level processing of information, decision making that goes with humans. It's hugely complex knowing somebody else's painful experience. In this particular paper 10 years ago, we tried to spell out some of the features of pain empathy. We defined it both in terms of cognition and affective responses. There's the sense of knowing the experience of another person in pain, and there's the emotional reaction to the recognizing the experience of the person in pain that give rise to the behavioral response. But what I want to focus on are the bottom-up influences and the top-down influences that impact on the experience of knowing and feeling the pain of another person. So this slide embellishes that to some extent. The bottom-up processes really are the things that are happening to the individual and how they are expressing their distress to other people. It's the incoming information to the person that's observing the other person. In contrast are the top-down processes, so it's what the observer brings to the situation by way of beliefs, attitudes, personal learning experiences, and the like, as well as the relationship between the observing person and the person in pain. So I'm going to begin by focusing upon the top-down processes and move on to the bottom-up processes because these represent the many ways the biases and the expectations of the observer, and these represent the objective sources of information that can be used. So to focus on the potential for bias perception of a sequence of slides that I love to show. Here's Daddy overreacting to baby's vaccination discomfort, or I guess lack of discomfort. Here's a mummy engaging in much the same pattern. Here's a woman who really doesn't convey the same level of distress as her child. Here's a young lad who has a very strong sense of empathy with his wee doggy. I like to point out that the expectation might be established by the size of the syringe that the veterinarian is applying here. So there are many potential sources of error in pain judgments, and I'd like to run through these briefly. The relationship between the person in pain and the observing individual is of particular importance. So the evidence seems to suggest that there's a stronger empathy, a greater capacity for getting into the painful experience of somebody else if we're talking about kin or friends, people who know the person in pain well. Professionals may have more difficulty truly empathizing by virtue of this professional relationship. Potential problems there. Socioeconomic status is implicated. There's good studies that show that people of differing socioeconomic status are not reacted to as empathetically, and indeed they just do not gain the same level of care as people of comparable status. There are all kinds of similarity and affinity factors involved here, and so it seems to be easier for us to empathize with people of our own age, our personal gender, our ethnicity, race differences are well demonstrated in the literature, and even such strange things as liking. If the other person appeals to us, we're more inclined to be generous in our estimations as to whether they're experiencing pain or not. So relationship factors are important as biases. There isn't a level playing field when you look at the relationship factors. There are certain cognitive affective dispositions that dictate the nature of our reaction to other people. So catastrophizing for ourselves or for the other person seems to accentuate the discomfort of the other person. We're more likely to become hypervigilant and estimate their pain at a comparable level. I recently gave a paper on failures of pain empathy, and in developing that paper I focused on the high incidence of violence and stress in our worlds, and you can trace a lot of that to socialization, to depersonalize or dehumanize other people. Suspicion of manipulation seems to relate to our capacity to empathize with other people. I'll come back to that in a moment. But I think there are institutional factors that prime our judgments of other people. Where do we observe them displaying pain critically relates to our judgments. And finally, comorbidity, when we observe biological evidence of pain, or even if there's evidence of psychological dysfunction, it influences our judgments of the discomfort of the other person. Most commonly, the error is to underestimate the pain of other people. That's true amongst healthcare professionals, true for family members, true for friends. Generally, we tend to be very conservative in estimating pain in other people. These are some of the factors that have been demonstrated to be associated with this problem in the literature. If there's uncertainty as to whether the other person is in pain or whether there's a sufficient basis for the discomfort, that's accentuated by an absence of a medical diagnosis. It'll contribute to underestimation. Again, I come back to the relationship factors I was mentioning a moment ago. The more distant the relationship to the patient is, the greater the likelihood of underestimation. There are some recent studies that show that likability of the other person relates to the generosity of one's judgment as to whether they genuinely are in pain or not. If there's strong evidence of psychosocial factors causing or exacerbating the expression of pain, then we become more conservative. And finally, patient social and language skills also seem to be related to the phenomena. It's hard for us to be empathetic for people who are dissimilar to us. So I'd like to briefly look at a variety of sources of pain judgments. I've already to some extent been talking about these. Pain-specific behavior certainly is the most important, but I've talked a bit about biomedical data, patient characteristics and contexts as having some impact on the judgment or the decision-making of the observer. What I'd like to do would be to elaborate on pain-specific behavior that's manifest both in terms of the protective actions of the individual, their escape or their avoidance behavior, whether they're guarded, whether they're protective of what's happening to them, or their communicative behavior, their use of language and nonverbal expression to communicate their distress. So let's focus on language and nonverbal expression. There are strong biases in the literature to accept pain as the gold standard for the expression of pain. Margot McCaffrey, the wonderful nurse educator, with her colleague Pastro, said this nicely in the statement, pain is whatever the person says it is, and it exists whenever the person says it does. Now, there are lots of ways of assessing self-report, simply asking others whether they're in pain or asking them to estimate their pain on a 0 to 10 scale is probably the most popular way of going about it. These are a variety of tools that are used in pediatric settings. I won't elaborate on them. This is a commonplace tool that I've used in clinics in which you ask people to describe their pain on human figures. This is a very extreme characterization of discomfort. Self-report measures can be very valuable. Our species is uniquely capable of articulating distress through the use of language. It does permit an accurate account of experiences. It's a good means of assaying the analgesic or other palliative impact. It's methodologically convenient. And there is strong advocacy to believe patients. I certainly sympathize with that point of view. But I like to point out that not recognizing the limitations of self-report means that you could be dealing with fool's gold. So the limitations of self-report include the fact that it can only partially reflect the complexities of experience. We know that people are often reluctant to report their discomfort. Depends upon the situation in which they find themselves. Many patients believe that clinicians will know, should know, and don't want to have others look upon them as complainers, so they inhibit their expression of distress. We know that language is used in a selective manner. Typically, it reflects the individual's perceived best interests in any given situation. One could cheat and fool other people if they only focused on self-report. I also note that it requires considerable cognitive and communicative competence to use this mechanism. So to move on to nonverbal expression, I like this quote from Nietzsche. It is true that we lie with our mouths, but with the grimaces we make when we do so, we still end up telling the truth. So nonverbal expression is important. This is a series of 1-second clips of these emotional and painful displays that I developed with Daniela Simone from Berlin and Pierre Rainville at the University of Montreal for research purposes. But if you look at the bottom line, you can see the neutral, the pain, the anger, the sadness, surprise, disgust, fear, and happiness expressions my point is that we use nonverbal communication extensively in our interactions with other people. A lot of my research is focused on the painful facial expression. We've looked at it in healthy adults, very young children, preterm newborns, and the elderly, and typically found that there's a relatively stereotypic display of pain that's consistent across age levels, which to some extent reflects the biological disposition that's inherited. Somewhat more complexly, we've come to conceptualize pain expression as a two-stage process in which there are both reflexive and automatic elements that can't be inhibited, that are most frequently observed during acute pain and exacerbations of chronic pain, as well as the more reflective, controlled kinds of expressions of pain that are subject to voluntary control and planning, that are not reactive so much as they're intended to influence other people, and they implicate these executive functions of memory, judgment, decision-making, and the like, exceedingly important because it permits retrospective accounts, and this is the kind of information that we rely upon in people who are suffering from chronic pain. I like this slide because it illustrates both the capacity to engage in self-control and the reflexive automatic expression of pain. I also think you can characterize empathic reactions, the reactions of observers, as being of two stages, both reflexive and reflective. The visceral gut reaction when we see others in pain, as well as the need to understand it, to organize our thinking, to put it together. If this slide has an impact on the listeners comparable to what I get in audiences when I get feedback from them, the appearance of the additional joint in Llewellyn Stark's leg will have illustrated both the automatic visceral reactions, as well as an attempt to understand what's happening, or maybe this one would be appreciated somewhat better by the men in the audience. So my complex model, and I gave the reference a little earlier in these slides, argues that to understand this capacity to know others in pain necessitates understanding both the automatic reaction of the observer to the automatic expression of others, as well as their reaction to the controlled expression, their contemplative active decision-making when they observe automatic expression, and the comparable reaction when they see controlled pain expression in other people. This expression is likely to instigate reflection on the credibility of the observer. So let me just make some brief remarks about credibility as it relates to these judgments. I think a lot of it is nicely summarized in this abstract from a paper by Werner and Mallored in 2003. Their title was, "It is Hard Work Behaving as a Credible Patient, Encounters Between Women with Chronic Pain and Their Doctors." My summary of the abstract was that it provides accounts of women with medically unexplained disorders encountering skepticism, lack of comprehension, rejection, being blamed for their condition, and suffering feelings of being ignored or belittled. as we know from patients, this is not an unusual reaction. We are biased to make judgments concerning the credibility of other people in all occasions of life. I won't go through these, but it's commonplace that we're obliged to establish the credibility of other people. There are many incentives for duplicity in life: financial, drug use, avoidance of work or domestic duties, manipulation of others. There are also incentives for suppressing pain. Sorry, the title doesn't come across here, but it reads suppressing pain. So people will suppress pain because they fear having the sick role imposed upon them. They fear diagnoses, drugs, needles, or other invasive procedures, or they just fear denial of roles, being dad, mom, granddad, grandma, and the like. So I'm going to skip that, but I want to say that perceived distrust is toxic in terms of the clinician-patient relationship. Once skepticism is introduced, it becomes very problematic to establish and maintain the rapport necessary to satisfactorily help other people. There are these risk factors in questioning the credibility of others. I'll not comment upon them since we're running short of time. I thought I would end up talking about the research project that I'm presently pursuing, because A, of the factors that distort how people communicate their distress to others, and B, the potential for biases in our judgments of pain in other people. So what we're trying to do at this stage of the game is to evaluate whether we can use computer assessment tools to objectively evaluate pain in other children. What we're doing is we're video recording children in the Rady Children's Hospital in San Diego and using computer vision, pattern recognition, and machine learning tools developed by computer scientists to establish whether, in the first study we've done, post-operative pain can be measured, and indeed the data is showing that the tool does work. We're soon going to begin to examine the clinical utility of the computer algorithms on nursing units in the hospital. Well, let me just summarize by with a couple of remarks. A, knowing the pain of another is not easy. I'm sure I've convinced you of that. That there is a substantial risk in making these judgments, and mostly the risk is of underestimation, with the consequence of that inadequate care. I think I've tried to describe some of the many sources of bias, both in how people represent themselves when they're in pain and how others judge their pain in these circumstances. I've tried to describe some features of objective and validated scales that might introduce some objectivity and diminish the bias. And in general, I hope that you've found this to be an educational and critical review of our understanding of this particular area. Thank you very much. Over to you, Tanya.
Great. Thank you very much, Ken. That was a very informative presentation. We do have some questions. So someone was commenting when you were discussing cognitive dispositions in sources of error or of judgments on pain, whether those were observer dispositions that you were discussing.
Well, at that particular point, I was. Our professional background is going to have a powerful impact on what we're looking for and how we interpret that. So I'm a psychologist. I'm much more likely to pay attention to cognitive and affective dispositions than I would be to the medical evidence of tissue disease and damage. Of course, this is the reason why multidisciplinary clinics exist. We find that combining the resources of different disciplines is necessary to really effectively take care of people.
All right, and then we also had someone who asked about the fact that often people might expect greater empathy from their spouse based on relationship closeness and some of those factors that you described, but that sometimes that is not the case, and that the spouse or partner might have less belief in their pain, and wondering if you could touch on that a little bit.
Well, extraordinarily complex, and we're only beginning to look at the spousal relationship. We, of course, know that marriages vary dramatically in their quality and the affectional ties. Yes, you would expect that the intimacy and the closeness of the relationship would enhance the empathy. I certainly can sympathize with that. It seems to be a bit of a double-edged sword in the sense that excessive empathy can mean too much solicitousness, too much caring. In some of the cognitive behavioral treatment programs, there's great emphasis placed upon reinforcing or supporting the person in pain for well behavior rather than excessive attention to the complaints, the disabled behavior, the invalid role. And so the interest to some extent is on encouraging positive rather than sick role behavior. Hugely complex factors involved.
Yeah, that is definitely the way it seems. Very, very complex. We have another question. What advice would you give for patients with chronic pain as they are having discussions with their GP around their self-reporting of their pain and having that taken to reflect the severity, like just generally that communication piece?
Right. Well, the unidimensional pain rating scale now is recognized to have very limited utility or usefulness in terms of how people communicate their distress and how other people understand it. Pain is just vastly complex. It has these cognitive and affective dimensions as well as the sensory qualities. Effective healthcare professionals enter into conversations with their patients that go well beyond the use of a numerical rating scale or a visual analog scale. So they'll talk about whether things are getting better, whether they're getting worse, what sorts of things exacerbate or minimize the discomfort. They take a long-range perspective on what's happening. So it's the social transaction, the interaction between the person in discomfort and other people that's we need to look at and develop further if we're going to move ahead.
All right, and then another question was around short-term pain versus chronic pain, and how there seems to be more of an empathetic response for short-term than for chronic, and if you had any thoughts on that.
Absolutely. So in talking about pain expression as two-dimensional, both the reflexive automatic reaction and the considered reflective expression, what happens in acute pain is that people are not in control of how they're expressing themselves. It's a less ambiguous expression of discomfort. The observer is less likely to look for other reasons why the person has reacted than internal painful experience itself. The expression of pain dampens very rapidly, even though the subjective experience can persist over time. And that's certainly the case for people suffering chronic pain. To some extent, the expression of pain is cognitively modulated. We suppress the expression of pain when we're suffering from some persistent or long-lasting pain because we recognize that there are adverse social consequences. We want to be appreciated as contributing healthy members of the community. So we don't like to let other people know that we're in discomfort. Chronic pain becomes more visible when there are acute exacerbations, when there are flare-ups or there's breakthrough pain. That's when you get these acute expressions. But ordinarily, chronic pain is not that visible to other people. It's silent. That's the expression we typically use.
All right. I think that's all of the questions we have. So I'm going to go ahead and wrap it up. For everyone online, thank you very much for being here. We are still finalizing our 2015 chronic pain webinar schedule, so you'll be getting email as soon as we kind of firm up those dates and get everything set up. Thank you very much, Ken, for your presentation today. It was really wonderful to have you.
Thank you, everybody. Bye now.
And we will see you all next time. Thanks for joining us.